Our department has been a leader in research for some 50 or 60 years, going back to the early days of John Campine, 2 chairmen ago. So I think it behooves us to every once in a while bring to your attention what's going on in our labs and in the clinical research so that you can stay abreast of our local developments as well. So the format today is that I will give a brief overview, kind of a quick dash through the labs, introducing who's doing what over there. Then we'll have 3 speakers, Julie Freed, Keri Hainsworth, and Tom Ebert, who will talk about their particular areas of research in a somewhat more detailed fashion. Questions are invited. So we have a very strong group of internationally famous mitochondrial specialists, as you see there. Amadou down in the bottom, that's not a representative picture. He's actually a very good-natured guy, but I don't know what happened to his departmental picture. Greg, you might want to work on that. So these scientists have undertaken to understand the mitochondrion because of its key role in health and disease. I'm sorry that the pictures aren't as bright as they might be. I guess we need a new bulb. But the mitochondrion, you may recall from your medical school days, is the source of energy. It turns fatty acids and glucose into ATP. Obviously, that's a requirement of every cell in the body. Indeed, 40% of the myocardial myocytes, 40% of their volume are mitochondria. We need that energy. A less well appreciated aspect is calcium management. They suck up peak calcium fluxes to manage calcium signaling and avoid such things as apoptosis, programmed cell death, which can evolve if that calcium isn't managed. It's recognizable, therefore, that any cell that has mitochondria is subject to mitochondrial dysfunction, and so there's a plethora of different diseases in which mitochondrial maladies are the source of the clinical condition. Our department has been particularly interested in myocardial dysfunction. So how do they do this research? Well, they have a wide range of very fancy ways to examine mitochondrial activity. For instance, Wei-Meng is looking at the VDAC channel, voltage-dependent anion channel, and I confess I know very little about the VDAC channel. Fortunately, Wei-Meng does. You can see in this diagram that the VDAC channel is in the outer membrane, not the inner membrane where all the respiratory activity takes place. And it manages multiple aspects of outer membrane function, and this is all very novel observations. What Wei-Meng does to examine the intimate activities of these individual channels is express them in an artificial membrane. You can actually build a piece of membrane that's 4 nanometers thick and install a channel in it and look at a single channel function after you have done various manipulations of that channel or taken these channels out of different kinds of animals who have different kinds of diseases. It's nice to understand the molecular aspect, but of course that only really matters if it changes the mitochondrial function. And indeed, they have the means of isolating the mitochondria. I was surprised to learn that you can pull the mitochondria out of cells and they don't just fall apart. They sit there and perform quite well. And they have these high-resolution respirometry devices that we've invested in that let them identify oxygen consumption. I'm sorry. Which indicates the health of the mitochondrion under various chemical conditions, as well as the transmembrane potential of that inner membrane, which is how we generate ATP across that membrane potential. So they can use these approaches to identify potential therapeutic sites. Finally, it really doesn't count if you can't show that it changes organ function. Our department, particularly Dave Stowe, was pivotal and is internationally known for developing this Langendorf approach, which uses a heart extracted from a rodent hung up on a device which has the means then of looking at the pressure generated in the ventricle. They use this fiber optic cable to look at redox potential according to the fluorescence of FADH and NADH. And identify shifts in mitochondrial function according to different conditions. For instance, an interest of our department has been the consequences of ischemia. And you can see in this diagram, if there's an ischemic interval during which the coronaries are not perfused, here's the ischemic interval. Thereafter, there's a very limp waveform of pressure in the ventricle. Whereas if you have some intermittent periods, brief so that they don't cause damage, this prepares the phase such that ischemia does not produce this impediment. This is a ischemic conditioning. And identifying the mechanisms at the molecular and cellular level of ischemic preconditioning would allow us to develop new therapies to treat myocardial ischemia such that even if there is ischemia, it doesn't do damage. After all, we see that ischemia does not always equal damage. Moving on, Karen Dean is a specialist in brainstem function, central nervous system. Brainstem is a site of regulation of responses to stress, highly relevant in an anesthesia department, and she's looked at autonomic regulation of heart function and peripheral vascular function for years. She's now working on a aspect of the overlap between cannabinoid organization of these processes with pain. They are both cited in the periaqueductal gray. And she has discovered that after a nerve injury, many animals become hyperalgesic. Some animals recover, whereas others go on to chronic pain. And identifying the mechanisms by which acute pain turns into chronic pain would equip us to better treat or at least prevent the evolution of chronic pain. And this is a transition that is not well understood. So she has identified that this enzyme, which regulates the level of endocannabinoids, such as anandamide, varies amongst rats as in humans. There are various isoforms and various levels, and it seems that this level of this enzyme controls whether the animal recover and avoid chronic pain or not. Therefore, this is a very potent possible site of manipulation in humans in the future. Bill has a background in neurosurgery, so of course this is a natural fit to carry on his work that he's been working with Jeff Binder in functional imaging. He will be looking at two aspects, identifying sites in the brain that you want to leave alone if the surgeon's going in there, not just because they're motor or sensory, which has been the traditional approach, but also language, obviously a critical feature that we don't want to mess up. So he's looking at functional images. We're very well equipped in this institution with high power magnets for looking at magnetic resonance imaging. Also, I was surprised to learn that nobody but Bill has looked at the possibility of using intraoperative electrophysiology, poking an electrode in as we do with our animals, to identify the electrical function of a piece of brain so that you can tell the surgeon, nope, you've gone far enough, that's no longer tumor, you can leave it there. That would be, of course, very valuable in avoiding damage from the surgery. My work has evolved in a couple of different directions, but one is looking at the mechanism by which an already issued FDA-approved and commonly used modality of treating pain, that is DRG electrical stimulation, how that works. It should, in fact, by our conceptual basis of what we know about what happens with peripheral neuron stimulation, it should cause pain rather than prevent pain. Our hypothesis is that it generates activity in the somata of these sensory neurons, which have the stem axon that branches into two different places, producing a point where action potential failure is likely, and doing so prevents access of pain signals from the periphery to the central nervous system as a block. We figured that, well, if it blocks that way, it should block this way. Neurons run both ways, and it's not well appreciated, but in fact, sensory neurons, especially the small fibers, the peptidergic non-myelinated pain fibers, have activity that originates in the central nervous system, and when it reaches the periphery, it releases inflammatory peptides like substance P and CGRP. Those processes play a role in a diverse set of conditions such as asthma, migraine, pancreatitis, and poor wound healing, but also in rheumatoid arthritis. And indeed, we used a model of rheumatoid arthritis. I collaborated with Ben Pan on this, in which compared to normal rats, when they inject the collagen, they get an autoimmune response and get all sorts of manifestations very much like human rheumatoid arthritis. And if we stimulate one side, we can stop it in its tracks. So this could be a potent way to avoid the complications of rheumatoid arthritis. Ben, who collaborates with Cheryl Stuckey and Cece Hillard and me, is an expert at CNS physiology. He has a background in addiction and depression. Of course, pain is bad, but most patients suffer not from the pain per se so much as from affective disorders such as depression. So he's looking at the question of how these processes take place in the brain. Again, this is an endocannabinoid possibility. We're very interested in these because they're not opioid pathways, and of course opioids have abundant limitations. He has technology by which he can take a slice of the spinal cord or the brain and look at individual synaptic mechanisms by what's called slice patch electrophysiology, and thereby look at the local network effects and how plasticity in these injury conditions of the rats affects these processes such that we can intervene. Chris is relatively new to our department, maybe 2 years I think, and his specialty is in functional imaging, especially in small animals. Our school has one of the very few 9.4 Tesla imaging systems for animals, such that we can do a number of different projects. He's looking at what happens after peripheral nerve injury. Even if it's repaired, the functional connectivity does not often reestablish such that dexterity isn't recovered. And we're looking at ways to address that. He feels that he can find a way to identify by this blood oxygen level dependent signal, the bold signal that underlies the functional imaging, which patients are at risk for strokes. Finally, he's working with me on looking at analgesia, because reflex behaviors that are easily measured in rats do not really represent what's going on in the full system of the brain, and we can look at areas such as the amygdala and anterior cingulate by these imaging techniques to identify whether our analgesic technology, our efforts in the animals would produce something that would be affectively efficient in humans. Chris is setting up to study traumatic brain injury. There's much study of TBI, but nobody has really gotten involved in looking at whether this changes anesthetic requirements or whether anesthetics change TBI, and should we treat these patients differently as far as their need for anesthetic levels and so forth. So he's setting up a lab to look at these processes using electrical physiology, biochemical measurements, and behavioral interactions. Astrid has long studied the respiratory consequences of anesthetics. Of course, this is fundamental in what we do. Our department, I think, was involved very early in looking at the respiratory effects of volatile anesthetics. She's gone way beyond this into the details, into the details of which parts of the brain are involved. She has the technology that lets her record and inject into specific locale of the brain to look at this complex system and identify by the readout of the phrenic nerve in this animal model in rabbits what is happening, for instance, during opioids. And this is a critical aspect, especially with regards to the question, are there age differences? So she's looking at neonatal rabbits to look at the function of these sites and whether we can design opioids or other chemicals that can avoid the respiratory depression that's particularly a problem in neonates. Dorothy is a scientist that looks at the world very different from the rest of us. We're interested in cells, neurons, myocytes. She's interested in everything in between, the extracellular matrix, and we sort of ignore it until Dorothy comes along and says, well, the ECM is actually a very active signaling system that interacts with the individual cells, neurons, myocytes, whatever they are, to dictate, at least in part, their function. So she has special expertise in the extracellular matrix signaling and red light. Sounds like voodoo. I confess that I was sort of surprised that we are shining red lights on animals and legs and vascular tissues. In fact, it is critically important, and evolutionarily, of course, we live in an environment, at least we evolved in an environment, maybe not now, living in basements, in which exposure to different wavelengths of light was very physiologically relevant. She's collaborating with not only cardiologists but also obstetricians to look at, for instance, what's happening in placenta as far as the extracellular matrix dictating whether there is problematic function and whether red light exposure can remedy that. Hongwei, finally, is a collaborator with me and Cheryl Stuckey, and he is a molecular wizard who has devised all sorts of clever ways to interact with sensory neurons genetically, and we do this by using adeno-associated viruses injected into the dorsal root ganglia where the cell bodies of the sensory neurons are. For instance, he can take this voltage-gated calcium channel, Cav 2.2, which is the N-type calcium channel, which is the channel that admits calcium in the dorsal horn for nociceptive neurotransmission. In other words, a passage of pain signals. You may have heard of zaconitide or Prialt, which is a chemical that you can inject therapeutically into the subarachnoid space, CSF. It produces a very nice pain block, but it gets up to the brain as well. His approach is to inject a virus into the dorsal root ganglion. The virus gets into the sensory neurons and delivers a peptide that interferes with a process as follows. This channel needs to get to the membrane to work, so it associates with this structural protein, which allows it to then insert into the membrane and become a functional channel causing pain. However, if you inject the adeno-associated virus, it produces a genetic product. This is a replicate of this little piece of the peptide sequence that then goes over and blocks up all the available binding sites such that this channel no longer can be inserted into the membrane. Well, voila, you can block pain. That's not to say that we're not doing clinical research at all. This is just the list at Fredert. There's a similar list of people who have IRBs for doing clinical studies, educational studies, and quality assurance type studies also at children's. So quite a few of these experiments are going on. It's easy to get involved in them, and I commend you to talking to these people. Two final observations. Ralph Waters invented our career. In 1927, he started the first anesthesia residency, which is 90 miles west of us at University of Wisconsin. In that residency, it was a 3-year residency back in 1927 and thereafter, and the middle year was a research year. So our heritage includes residency training in research. And if you think that's an impossibility to do something important or useful, I give you one final example, and that is Rao Malampati. He was a predecessor of mine at the Brigham residency, and he was there as a junior faculty when I was there. And his chairman, Ben Covino, said, we're an academic department, you got to do something a little bit academic. And he said, well, I'm not trained in science. And Ben said, well, there's things you can do. Think about a clinically relevant question. So he went around and looked in 200 mouths and correlated that with intubation challenges. And now Malampati is one of the most recognized names in clinical anesthesia. So there are possibilities out there. I turn it over at this point to our next speakers. Julie?
Okay, good morning, everybody. I'm going to try to do this kind of quickly because we have 2 other speakers going on. So this should just excite you right away, right, the vasculature. So I see you guys, at least the residents, on Mondays, usually in the heart room, and then the rest of the week I disappear. And I disappear to my lab. It's over in the cardiovascular center. And we are a vascular group. Can you hear me? Can you hear me now? Can you hear me now? Good, okay. So we are a vascular group that primarily looks at the microvasculature, the teeny tiny resistance arterioles, and we look at something called microvascular dysfunction. So I'm not going to show a lot of data actually, which makes me sad, but I think what's more important is that you get an idea of why we're doing what we're doing. And so I'm going to inject just a little bit of fear into everybody right now, and that we know our population is changing, right? So we know there are a couple of epidemics going on currently. I'm going to tell you about 3 of them real quick. The first one is the obesity epidemic. We've been talking about this for years. The bad news is it's getting worse, okay? So by the year 2030, 50% of all U.S. adults are going to be obese. So there's no point in having our obesity rotation anymore, right, in this residency, because we all have to become experts in dealing with obese people. The second one I talk about is the aging population, right? The silver tsunami is coming. Age over 65, that's the fastest accelerating group we have right now. And by the year 2030, we're going to have over 2 billion people over the age of 65. Everyone's going to be old. It's going to be great. And then finally, there's cancer, right? Cancer's increasing. You know, you go home and you watch TV and you see, you know, commercials, Cancer Centers of America. There are cancer centers popping up everywhere. Why is that happening? Well, because of problems number 1 and 2. Obesity is linked to certain kinds of cancers. And age, you could argue, right, kind of causes cancer. The longer you live, the more likely you are to develop cancer. So all 3 of these things, and of course, again, there's other problems we're facing right now. But for someone who studies the vasculature, this worries me because all 3 of these things cause vascular dysfunction, specifically microvascular dysfunction, which precedes cardiovascular disease. So before you have atherosclerosis or coronary artery disease or heart failure, you usually have some sort of microvascular dysfunction. That's what we're trying to figure out. So cancer itself doesn't cause problems with your blood vessels. It's actually the cancer treatment. It's the chemotherapies, the radiation. So I'm not trying to be a pessimist, but in about 10 years, these are the people we're going to be taking care of. They're going to be obese, they're going to be old, they're going to have cancer, they're going to be in chemotherapy, radiation, and their vasculature is just going to be a wreck. So by 2035, we're anticipating that almost half of the U.S. population will have some sort of form of cardiovascular disease. This is going to be a huge financial burden on us too, right? And these are the patients, again, that we'll be taking care of in the operating room. So as far as my lab right now, the kinds of projects we're doing, again, all revolve around the vasculature, of course. The main one we're looking at right now, this is what my FAIR award was on and now my NIHK award. We're looking at something called, they're called sphingolipids. These lipids are known to be elevated in cardiovascular disease. They go up in people who are treated with chemotherapy. And we're looking at ways of trying to kind of reverse that microvascular dysfunction and manipulate those lipid pathways. We are going to take it one step further. Right now, there is no simple way to determine if someone has microvascular dysfunction unless you take them to the cath lab, right, which is pretty invasive. That's the only way we can determine right now if someone has microvascular dysfunction. So we're working with a company right now out in the Netherlands to use an imaging device in order to basically place it under the tongue and figure out what you're vasodilating to and whether you're dysfunctional. I would like to know, right? Because again, this is going to precede cardiovascular disease. So the idea is people who are placed on chemotherapy, we can use this device to do early detection. I do stuff with vasoplegia because I'm a vascular lab, right? I can do other projects that don't have to do with maybe sphingolipids or specifically microvascular dysfunction, but I can utilize our techniques to look at problems we face in the operating room, like vasoplegia, low blood pressure, whether it's due to ACE inhibitors and ARBs and then you put that person to sleep, we're working on that, or whether we are trying to figure out how vitamin B12 increases blood pressure. And then finally, I'm starting to do more clinical trial work. I consider myself a translational researcher. I want to be in the lab, but I want to see those things translate right to the hospital and what we do. And I'm going to talk just briefly about one clinical trial. It's called the Prehab clinical trial. And then finally, I'm doing some other trials that are more collaborative with our cardiac surgeons. So, the Prehab clinical trial. So again, right now we do about 50 million surgeries per year. That was based on data from 2015. About 1/3, 36% of all these surgical patients are over the age of 65. And based on what I told you, we know that number is going to go up, right? So in the future, these again are going to be your patients. You're going to see this guy sitting in a wheelchair. He's frail. What does that mean? He has decreased physiological reserve. He's weak. Just because you're older doesn't mean you're going to be frail, but you are more likely to be frail the older you get, right? It's not going to be that 80-year-old who's out on the tennis courts or the golf courts every other day. It's going to be that person again who looks like this, who just has no energy, who has poor nutritional value. So our idea or thought is that we can take these patients and prehabilitate them before they come to surgery. So why do we want to do this? So if we look at this graph here, We're looking at functional capacity over time and frailty. So obviously this would be high functional capacity. This would be, kind of seems not so clear, but this would be a high amount of frailty, right? They're inversely linked. If you take a healthy person and put them through surgery, they usually start out with a high functional capacity, right? You have surgery, and for the time being, your functional capacity goes down, but really you should respond well after surgery, come back to baseline, everything returns back to normal. If you take someone who's frail, who's elderly, who's weak, their functional capacity, they start out pretty low. They have the same surgical insult, their functional capacity goes down, and most likely sometimes they don't even return back to their baseline, right? Grandma's not the same since she's had surgery. Not only is this hard for the patient and the families, but again, it's also a financial burden, right? These people stay in the hospital longer, they have more complications. So the idea is that if you prehabilitate them, increase their functional capacity prior to surgery, they'll still experience that dip in their functional capacity, but the idea is that hopefully they return more so to their baseline, or at least better off than they would if they weren't prehabilitated. And the question for us is this improvement right here enough to improve those outcomes that I talked about? So how are we going to do this? We are going to use something called remote ischemic preconditioning to improve their vasculature, which will essentially improve their functional capacity prior to surgery. So remote ischemic preconditioning is a pretty simple concept. It's been around for a long time. It's when you take a blood pressure cuff, you put it on the arm or the leg, you make the limb completely ischemic for 5 minutes, you do a couple cycles of that, that's pretty much it. The idea is that by causing limb ischemia, you're causing buildup of compounds and other things that we probably don't know about that get released into the vasculature, and we think it's increasing your endogenous mechanisms for protection. So it's kind of like just beefing up the vasculature before these surgical insults. So we know that remote ischemic preconditioning, this is work done by my colleague in physical medicine and rehabilitation, improves walking speed, and we also know that it improves vascular function. So, and this is done by Matt Durand. This is the first time that anyone's shown that remote ischemic preconditioning actually improves functional capacity in a frail population. This was done in chronic stroke patients. So our primary outcome is we're just going to try to improve the frailty score in frail patients prior to surgery, and they're specifically going to be colon cancer patients. Secondary outcomes, we are going to look at blood pressure variability intraoperatively, and also look at the frailty score 4 weeks post-op. And of course, everyone's always interested in, well, yeah, but what about those other outcomes? Length of stay, morbidity, mortality. You'd have to have a really big clinical trial in order to see those changes, and that'll be the next step. And we did just get a really nice score from the National Institutes of Health to get this funded, but the government shut down right now, so we'll see what happens. So this is the plan, this is the outline for the prehab trial. I don't have time to go through all this, but basically, again, these are going to be colon cancer patients aged 55 to 85. We're going to go ahead and test their frailty through a couple of different means, but the gold standard is the 6-minute walk test. Basically, how far can you walk in 6 minutes? If that's low, then we're going to randomize them. Either you get remote ischemic preconditioning or you don't. And then we take them back to the translational research unit here at Froedtert the day before surgery, test their frailty again, look at their score, take them to the OR, pull out that data, look at their blood pressure variability, and then test their frailty score again 4 weeks post-op. So based on our power analysis, we only need about 96 people over 2 years, but with a 20% attrition rate, that'll actually be less. So it's definitely doable. We can do that in 2 years. This is the prehab clinical trial group. It's myself along with Matt Durand and PM&R. This is a highly collaborative effort that also includes, of course, these guys. These are our colorectal surgeons, Keri Peterson, Kirk Ludwig, and Tim Rodolfi. They're co-investigators on this grant. And of course, I think you know these lovely ladies. So Dr. Lauer, Dr. Pinkerton, they're in the high-risk anesthesia clinic. They've been helping us out to organize this. And then I have a medical student who will be with me for the next 4 years working on the blood pressure variability part. So clinical trials require a lot of organization, just research in general, right? Grants, IRBs, all things like that. So I just want to make a quick announcement that for the first time, I think, in our department's history, we finally have a clinical research coordinator. And her name is Lisa Zemblowski, who's here. Okay. So Dr. Lane is going to be making an announcement soon that she can provide some services, right? She's going to help us with IRBs, with grant submissions, dealing with OCRIC. If you don't know what OCRIC is, that's kind of a problem too. They're our main compliance office for doing research. She can help navigate all these things. And I also want to point out that we are making efforts to increase the amount of clinical research being done in our department. And you can find all these resources on ANET. So we've been working on that. So Lisa's contact information is here, but again, a more formal email announcement will be coming out. She's kind of being shared right now between basic science and clinical research, but we did find some space for her in the hub. So if you ever want to meet with her, talk with her, just contact her. She's over on the 3rd floor over there. Okay. Hopefully that was fast. Yes, Dr. Tweel. Wait, what's that?
Your research interests?
Yes.
And you stuff all of your employees full of donuts on Fridays?
Yes. How do you know that? How do you know that I do that? Yes, I do. I do. Did you want a donut?
You're always passing me donuts.
I know.
I feel like you're trying to kill me.
That's a good point. I should probably stop that.
Actual research candidate.
Ooh. Sure.
Yes, sure. Good morning. Hopefully my throat will hold out a little bit while I give you a little bit of information about research on children. I'm the research director of the chronic pain program, acute pain program, and we do a wide variety of studies. On the acute side, we have done a variety of studies on PNCA, PCA, and that's a study I'll talk about today. And on the chronic side, we are very behaviorally based. I'm a research psychologist by training, so we do a lot of work on what perpetuates, exacerbates, and hopefully alleviates pain in kids and teens. My area of expertise is really the overlap of obesity and chronic pain, and I'm currently running a AHW funded study looking at the benefits of a 3-minute yoga pose on endocannabinoid levels in kids with and without pain, with and without obesity. Wide variety of research studies. Today I'm going to talk about just a study that we recently did that's very practical and very informative, I hope. Let's see here. This study was funded. I have to acknowledge our funders. It turns out that a couple of years ago we had to purchase new PCA pumps at Children's, and they happened to come with some technology. And previous to this new technology, never before for adults or children had the patient any indication of whether or not their button push would result in medication. And the literature shows us that that's anxiety eliciting. We feel as though we're imparting control to patients when we give them that button. But what we don't realize or hadn't realized really until this technology came out, that that was anxiety eliciting for folks and they didn't like it. So we bought these new pumps and they happen to come with technology. The green light comes on when the lockout period's over. If I press the button, it actually flashes indicating to me that medication's being delivered, and then it goes dark during the lockout. So it seems on the surface a very helpful thing, a very informative thing. And in fact, there's an adult study that polled adults after surgery and experience with PCA, and the investigators asked them, of this list of technological improvements, what would really make this, what would have made this a better experience for you? The vast majority said, gosh, we wish that thing would light up. We wish we could know if we were getting medication. So here we are now at Children's, and we saw immediately, though, that we needed to study this. We couldn't just roll this out for kids. And this is a little bit busy slide, but I'll tell you that we saw an opportunity, but also as a psychologist I saw that this could be very dangerous for kids. Not only was the light green, which could be meaningful, but if you remember anything from Skinner, B.F. Skinner, or back into those psych days, what we know is that using this kind of a signal the terminology would be we're putting kids under stimulus control. In other words, it was very plausible that kids would start to press the button in response to the light rather than in response to their pain. And that could be a bad thing because they could end up getting too much opioid and with all the complications associated with that. And so technically at the bottom of the slide, at the bottom of the slide here, in Skinnerian terminology, it would be akin to putting a child on a fixed interval schedule of reinforcement. And what that is a maintenance schedule. We use those purposefully to promote long-term behaviors, strong behaviors that are resistant to extinction. And if we do this with PCA pumps, we don't know what the effects would be. So we designed a simple study, 2 arms. What you see here is the experimental group, we call it the light group, and the control group. For the control group, the light just stayed on continuously. For the experimental group, it did what I just referred to. Our main outcomes were opioid consumption and state anxiety. And we asked 3 simple questions. We wanted to know if satisfaction would differ, would the light be beneficial, and would the light affect how the PCA was used. I don't want to take too much time to go through these, but we wanted opioid naive kids who were likely to use a PCA or need one after surgery. Now, what you see on this slide are our main outcomes: pain, opioid use in milligrams per kilogram per hour, and state anxiety. A couple of things I'm going to note before the big yellow box here. What I want to show you is that these are T-scores. And so using a state anxiety measure, it's not really a surprise, but 63% of our population is clinically elevated in state anxiety pre-surgery. But that comes down to a moderate level afterward. In terms of pain, it was fairly well controlled and didn't really change too much throughout. But the big story of the day is the big yellow box in the middle. And what we found was that one of our hypotheses was confirmed. Kids in the light group, kids and teens, were consuming more opioids, significantly more than kids in the control group. And I'll show you on this next slide that is mostly attributed to children 12 and under. So you can see here that the teens really didn't differ, but the children did. So these are kids in the light group. So what you're going to see here, you see on this slide is clue number 1. What I think is that when we look at the overall pattern of results, we see a pattern that suggests stimulus control of behavior. So that was clue number 1. Clue number 2, important question would be, is there a relationship between pain and opioid consumption? And what you see on this top panel is the control group data, days 0 and 1, post-op days 0 and 1, and we're plotting opioid consumption by pain intensity. And what we see here is a significant and strong relationship between those 2 variables, what we would want and what we would expect. Now, the bottom panel shows the light cues group. There's no relationship between pain and opioid consumption in the light cues group. So clue number 2, that something's going awry. Clue number 3, we wanted to look at the ratio of injections to attempts. In this literature, that's an important outcome. And so what you see here plotted, this is a simple histogram, and so you see number of kids basically across the injection to attempt ratio. And so a perfect 1-to-1 means no button pushes during lockout ever in a 24-hour period. So what we see here is that kids proportionally more, and I'm sorry this is a little chopped off, I think it's 34 kids, and so proportionally more kids across post-op day 0 through to in the light cues group had that perfect 1-to-1 ratio in comparison to a smaller proportion in the control group. Now, this last slide, I know is my joke, my lame joke is don't bash me on Twitter. I know it's busy. So, the top panel, what we're plotting here is the injection to demand ratio over average pain intensity per hour. And what we see in the top panel is the control group data. And you see a lot of scattered data points, basically across a range of pain intensity values. The injection to demand ratio is fairly low. There's a lot of button pushing during the lockout for these kids. And I forgot to say in the beginning that that's an indicator of anxiety. But then what we see in the bottom panel is the data from the light cues group, and you see that very high clustering right around the 1-for-1 ratio across a range of pain intensity there. And so what that suggests to us, along with the pattern of data that we've seen, is that kids, especially children 12 and under, are pushing that light in response to the light, pushing the button, sorry, in response to the light rather than in response to their pain. And so I think that's my last slide. So we did just get a CTSI grant to follow up on this study, and what we want to do is we want to look at behavioral phenotypes, and we want to conduct qualitative interviews with these kids to find out why and when they actually push these buttons. But we also plan to do some neuropsych testing before and after surgery to see if there are any behavioral indicators, for example, impulsivity, that might predict this sort of behavioral pattern, because it wasn't just children 12 and under who were pushing that button in response to the light. It was others, it was teens as well. And so what we want to do is look to see if we can determine predictive phenotypes for long-term opioid use and potential misuse. So thank you very much.
Good. And last, hopefully not least, is a little bit about another type of research that people can be involved in. And I do want to put a plug in for a training grant. So we have an NIH training grant that we can take residents or fellows or PhD candidates and fund their time in research labs and develop that part of your career. It's something that we could certainly offer to residents working with Dr. Ellenis and the education residency team to foster in you if you have an interest in this. This is a fun slide to point out that there is more types of research than the bench research and some of the translational research that Julie referred to, and Keri touches on research and psychology, and we've done some number of clinical studies over the years, but we currently have some funding to look at education topic, and with the Foundation for Anesthesia Education and Research. So Dr. Chris Fox and Jacob Mishka, who's one of our computer people in the department, doing some work that helped develop residentprogram.com, and myself and some participants. Steve is one of our interns who had some research time in his internship year and has been instrumental helping organize some folks into developing rating systems to help evaluate you as residents, right? So beyond milestones, you've all heard about the milestones, global ratings to evaluate trainee performance. So we put this proposal into the fair expecting it to get rejected or returned for revisions, and sure enough they got excited about it and funded it on the first pass, so it came quickly. As you know, you are evaluated in milestones, and from our perspective I believe they're more check boxes than really thought-provoking processes. And we may not really be offering you feedback on how you're progressing to mastery of your specialty. So what we proposed is something along the lines of work we've done earlier, is going with your gut instinct. So I work with you in the OR, and I have a sense if you're sort of where you should be in terms of level of training and dealing with patients and communication skills and the team environment. And so we want to do is try to assess your performance based upon our instinct of how you're doing just from our day-to-day work with you in the OR. So we came up with a phrase, interpreted professional activities, and this is where we develop case-specific scenarios that we'll ask our faculty about, say, you know, do you think this resident can handle this sort of case, and rate that, and we'll get into that in just a slide or two. Currently, we have 25 milestones, and we have assessment pieces. It would be very cumbersome for us to have to evaluate in 25 areas every month. So we've sort of broken those down into subspecialties, and not all the milestones fit all the subspecialties. But these are the top types of evaluation forms that we have currently available, and I think Libby Ellenis years ago and Jacob Mishka and a group at Whitewater that helped develop some of the software for this. To give you an example of how it looks from our perspective, this is a patient care milestone. Patient care is question 3 in the pediatric evaluation form. Residents in pediatric care should be able to develop an anesthetic plan and be able to deliver it in a safe manner. So we rate you. We click a box, right? So I think rarely we hit this blue item here that says show descriptions, because we can really think about you in a more detailed way. So we've written descriptions of what this question refers to, right? So question 3, patient care. A CA1 should be able to achieve the items listed in the top paragraph, right? So, and a CA3 should be able to formulate and tailor anesthetic plans for very complex patients. So we do sort of go with a gut. We rarely click these descriptions. We just say, well, he's a CA3, and gosh, he's doing well in the OR. I'm going to rate him, you know, sort of high in this CA3 category. We rarely dig into this subhead. In fact, our overall performance evaluation of you on our form, this is the descriptions. So if we say you're a CA1, we click on that. What does that mean? And the description is that you're a CA1, right? So it's not perfect. It works for us, but it's not perfect, and can it be better? So these IPAs that I referred to are sort of case-based, specialty-based scenarios, and I wanted to give you an example of something that Dr. Kula and I are working on for OB anesthesiology. So I, as a faculty working in OB, at the end of the month, I would be presented with these 2 scenarios, and I would say, well, how is resident X doing in these areas? Give us your gut instinct, right? So a routine case would be one of the scenarios. It's a C-section. We do plenty of C-sections, right? So a lot of our patients have some preeclampsia. We occasionally get into some hypotension and some nausea, right? So that's sort of routine. We all should be able to do that at some point. And we'll rate you. If you're on your first month of OB, you may be very average in our gut sense of how you're doing. We've worked with you. We'll rate you on a 5-point scale, and it'll be, assuming there's no billing requirements, do I have to be there the entire case? Like, is this resident really sort of need that attention for a case like this? Or level 5 would be, hey, you know, I don't even have to walk in the room. That resident is doing so well, they can just go ahead, pop the spinal in, take care of hypotension, take care of nausea and vomiting. And again, we have to be there because of billing requirements. Also, there would be a complex case set up for that end of the month rotation in OB, and it would be a crash C-section. So you may not have been in a crash C-section, but I think if I worked with you enough, I would have a sense of how you do in that crash C-section, right? So placental abruption, right? You need IV fluids, you need extra IVs, you got to induce quickly, sometimes without monitors, you've got blood loss issues, right? So what's my sense for how you would handle that sort of case and rate you in that? So someone in a CA 1 year might get rated pretty high on that routine case, maybe very low on the complex case, but someone progressing in residency might be rated higher in the high on both cases, right? So that's what we hope to investigate. And these things would, of course, have to be map to the milestones, because the milestones are what's reported to the ABA, right? So we're still in a milestone-based system. But you can see where, if I think about a C-section and a routine C-section, these are sort of the milestones that I think would be touched by that. So we have to map these case scenarios to the milestones, because currently we're in a milestone-based system, and that's our reporting system. So that's the research. It's education research. We'll ask also a couple extra questions about communications and professionalism, just sort of yes/no questions. They might be a 5-point Likert scale as well. And we're asking these 3 questions. Do these IPAs, these case scenarios, correlate to milestone evaluations? If so, which ones? Do the ratings relate to case log numbers or months in training, right? So if you haven't had much experiences early in training, there may be a relationship to the number of cases that you've done or how many months you have in training. I suspect there will be a relationship. And importantly, is this system more useful for you, more satisfying for you? Instead of having a number, a report that gives you a number, if you thought about a low rating and you sort of looked at, okay, well, they don't think I can handle a routine C-section. Goodness gracious. You know, I spent a month on OB at Freighted. We did 30 C-sections. That may be more useful information for you, and hopefully get feedback from your mentor or the rater about why they think that way. That's it.